I'd like to welcome everyone to the Trauma-Informed De-Escalation and Engagement Strategies presentation. My name is Michele Paliotta. I am currently teaching at Rhode Island College in the Bachelor of Social Work program. I also maintain a private clinical practice, primarily focusing on the health and well-being of LGBT folks. Previously, I have worked for the Rhode Island Family Court, providing diagnostic clinical evaluations for juveniles. In addition, I have also worked in child welfare, including working in residential programs as a direct care staff and a clinical staff. And I've also done some work in regulatory compliance in regard to DCYF in Rhode Island. So I welcome you to this presentation, and certainly anyone is welcome to contact me after if you have any questions that you'd like to follow up with. So today we have three main objectives. The first important objective today is to understand the contributing factors of client presentation using trauma-informed care. So this includes both internal and external factors that can contribute to the way that folks you work with present on a day-to-day basis, and learning how to interact with them in a way that is more healthy and effective for all of us. Secondly, I'm going to provide some practical de-escalation and intervention techniques. So these are really the hard and fast skills that we can use on a day-to-day basis while performing our jobs. And lastly, I'd like to talk about self-care techniques, because the work that we do is incredibly difficult and we have to make sure that we're taking care of ourselves so that we can take care of others. So let's start. How do we define trauma? Trauma is a really broad word that I think more and more frequently is being used in day-to-day language, and in some cases that oversimplifies what trauma means. But also it's important that we're talking about trauma and understanding that things can have a great impact on individuals. So trauma is an individual's response, meaning it is very specific to each person, everything that they have experienced. So it can be a response to abuse, violence, neglect, maltreatment, grief, or other overwhelming experiences. Again, within each of those listed, the abuse, the violence, neglect can fall a number of items, and we'll talk about that a little bit more in depth. Trauma is also represents itself with behaviors, right? So we'll learn about the biological impact of trauma, but also how it presents itself. So some people would identify it as maladaptive behaviors, or maybe coping skills that aren't so great. The reality is that when we don't have, or a person does not have the healthier skills to manage or cope with trauma, we sometimes use not so great skills to cope with trauma. And it doesn't necessarily make them bad. It just means that that is what was accessible in that moment or for that time period. And if those are not the healthiest coping skills or behaviors, then at this point, now that we're working with folks, it may be that it's our turn or our time to work with folks to provide them with healthier coping skills or new options to managing difficult emotions or overwhelming emotions or trauma. So some experiences that may be traumatic for different people are listed here. Now, these are very broad topics, right? So physical, sexual, emotional abuse. When we think about trauma, again, it's very broad, and so physical abuse can look like and exist in many different ways. The same for sexual and emotional abuse. These are not great things that we like to talk about, but they are the unfortunate reality for many of the folks we're working with. And so we need to think broadly when we look at these topics. Childhood neglect, again, can look like many different things, and people can experience them in many different ways. Living with other family members or folks in your direct, immediate community with mental health or substance use disorders as a child, adolescent, young adult. Sudden unexplained separation from a loved one. This can be, particularly for children, incredibly upsetting and traumatic, because all of a sudden a person that they've always had is gone for various reasons, whether it may be death or incarceration or substance use, and they're just not around for a while. So it is unsettling because someone or something that was a constant now cannot be relied upon. And so it creates a lot of uncertainty. Poverty also can be traumatic. So what are the impacts of poverty? We need to think about having less access to things that folks need on a day-to-day basis and having to find ways to get basic needs. Racism, discrimination, and oppression. So some of these are direct day-to-day interactions, and some of these are institutional or system-wide issues that are built into our day-to-day lives that we feel or our clients feel in very intense ways. And over time, we can become a little desensitized to them simply because we experience them over and over and over again. That does not mean the impact is decreased for folks. And lastly, violence in the community, war, or terrorism. So unfortunately, right now in the world, we're experiencing this at a very intense level. So there is global concerns about war, and also there are very intense issues of violence in the community related to poverty or economics or other issues that are happening. So what I want folks to understand is that the traumatic experiences can be individual issues, they can be long-term issues, or they can be many issues together at the same time. So what is trauma-informed care? So trauma, and historically, we've always looked at folks as in, what's wrong with you? So why are you behaving this way? Why can't you behave better? Or why can't you manage yourself better? Or why can't you make better choices? So that's a really blaming approach and a negative approach. And really, if you think about yourself, if someone asks you, why are you doing that? You immediately feel defensive and like you have to justify or find reasons for what you're doing. The reality in trauma-informed care is that we talk about or look at it from what happened to you? What's going on? What helped to create how you're feeling now? And this takes away some of the blaming and shaming feelings attached to getting treatment or getting help. So trauma-informed care helps to improve client outcomes, which is exactly why we do the work that we do. Otherwise, we wouldn't be working with folks to hope that they can get better and move on from treatment. It also helps to reduce staff burnout. So it's a win-win for everybody. Staff get to feel more effective and useful for clients, and clients get to feel like they're really making positive gains. So what I would like to do is just show a short clip. It's about 3.5 minutes, and it just gives a little introduction about trauma-informed care.
Saying, don't judge a book by its cover. Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made. Plus, our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
Okay, so my hope from that short clip is that it, in fact, does instill hope. I know that we're talking about trauma, which can be a really intense conversation and sometimes can feel really depressing or overwhelming that so many bad things can happen for folks. But trauma-informed care really works to instill hope for providers and for clients because, in fact, it provides and gives the skills to create positive change for folks. Okay, so historically, we talk about what do humans need to exist in the world in a way that feels okay and provides loving, healthy, supportive functioning in the world. So when we think about the folks that we work with, or even about ourselves, we have to start with what are the most basic physiological needs that all humans require to exist. So at the most basic level, food, water, sleep. So if we think about those needs in relation to our clients, what are some areas where maybe they did not have their most basic physiological needs met? What if there was not enough food or water, or any water, frankly, or water that was not contaminated? And what if it was not safe to sleep, or maybe there was not space to sleep? So you see, at the very beginning and the very basic level of human needs, it's very possible that there were some areas of need for our clients, or areas where they were not getting basic needs met. So now, as we work with our clients, we need to think about and connect some of what happened to them in regard to lack of food, water, sleep, for example, and how come they're having the issues they have now. For example, hoarding food or not sleeping 8 hours a night, which frankly, I don't know many people who can get that much sleep these days. So we have to try and think about what else is motivating our clients to behave the way that they do or act the way that they do. And sometimes it's because we're tired, because we're overworked, because the work is difficult. We say, oh, they're just being difficult. Oh, they just want to be manipulative, or, oh, they just don't want to go to sleep so they can cause problems later. The bigger picture is they may have had a history of not having regular routines and not having regular day-to-day food, water, sleep, basic needs met, and they're still presenting now. The second level that we look at is safety. So safety, again, is a really broad topic, but what does safety mean? Safety is, do I know that I have a home or a place to go back to every day when I leave the house in the morning or wherever I'm living in the morning? Do I know when I come back to where I'm living that it's going to be clean, neat, and consistent? Do I know who the people are going to be at the house when I return? Do I know if there will even be people at the house when I return? Will there be strangers that I don't know? So a lot of uncertainty creates more anxiety. And for children in particular, they need consistency. Adults, we all need consistency. And so when there is a question of safety at the second most important need, it can present itself in very anxious behavior for our clients and lots of questions and concerns about, for example, you may have clients who are constantly asking who's working which shift. Is so-and-so coming in today? I thought so-and-so had today off. Why are they here today? So at times, it seems like these questions are intrusive or excessive, or we just don't understand because we're too busy. But usually they serve a very real function for people who are trying to assess their safety in that place or in that moment. Now we move up to love and belonging, right? So if you think about yourself, we all need to be loved. We all need to feel like we belong. We all need to feel like we have friends or community. If you don't have those things, frequently we start to think, well, what's wrong with me? No one can love me, or I'm not able to love or belong. And the longer we experience not being loved or not belonging, the more we start to believe we are unlovable. And that can present itself with our clients as people really having a difficult time getting along with the community and fitting in with the community. So all of these things build on each other and can present in similar ways, but can mean different things. And part of me providing this information is to help you have more tools to understand how come people are doing what they're doing and how you can better intervene for both the client's well-being and treatment, but also for feeling more effective as a staff providing the treatment. The next level we talk about is esteem. So feeling like you can accomplish things, feeling like you're good at stuff. So it builds, you can see how the pyramid builds. The skills provide the foundation for the next skill. And it's really difficult to have esteem and feel like you're useful and productive when you haven't had the other basic needs met. At the top of the pyramid, we have self-actualization, which is a really fancy word for just feeling pretty good about myself and feeling like I'm living my life in a way that feels good to me and looks like it feels good to others. So in general, I can be a good person. So you can see how the other foundation of the pyramid, the other 4 levels, create the foundation to allow a person to feel good about themselves and the way they interact in the world. What I want folks to also consider is some of the other environmental factors that contribute to how clients present. And by identifying the factors, we can then use this information to better intervene and understand our clients. So within the pyramid of needs, we also think about income. So what is the income? Is there an income? Is there a consistent income? How are we getting income? What do we need to do to get income? So how are folks generally getting the means to live? And when you're working with folks as your clients, this may present in lots of different ways. And so this is just another factor to consider when you look at how folks are presenting to you on a day-to-day basis when they come in for services, or if you're working with them in residential. Nutritional risk. So what is folks' access to healthy foods or any food? And what does that look like when you're working with them? So being hangry, right? If you haven't eaten, I know for myself, I'm really cranky. And so it's always, in my office, I keep a closet full of snacks and food to offer folks, simply because that is one of the most basic things as providers we can offer, is a drink of water or juice or a snack. It goes a long way and can build rapport with your clients. Housing, we've talked a little bit about at the second level of the pyramid. So what is the stability of the housing situation or instability, and how does that impact the client and the way that they present when they come for services? Pregnant and parenting adults or teenagers that we may work with comes with an entirely different set of needs and presentations. So how are folks feeling about being pregnant or parenting? What does that mean for them? And how might that upset their pyramid of needs, right? Because being pregnant and parenting presents with different challenges, and also presents with hormonal changes and different needs for folks, and impacts pretty much everything in a person's life. And so that may be something we need to take into consideration as well. So interaction with the justice system, and so clients' history with the justice system and what they've experienced and been through, what their current status may be with the justice system, and what their potential status may be. Many clients have a history of incarceration or legal involvement, and many of them are waiting on pending involvement. So a lot of that can create anxiety, which can present as what we would think about as people maybe being a little bit more difficult to work with, or standoffish, or argumentative. I bring up these issues so that it's more information for you to use when you're interacting with your clients, things to think about or ask about or be aware of. Other issues, institutional barriers and racism. Historically, how has this person had to interact with the world, and how has the world interacted with them? And what are the barriers or the difficulties that they seem to face on an ongoing basis? And sometimes we're not in a position to change those immediately, but just acknowledging them can help to ease a client and just let them know that we know that this is something that's happening for them. Other factors to consider, there may be some that are more specific to your agency or your population or where you live. I know that folks in the LGBTQ community are also at higher risk for experiencing a lot of difficult situations. And so that also contributes to how they present and the issues that may come up for them. And that's when, you know, a person's gender or sexual identity is something that may not be present or spoken about. And so there may clients have good reason to be protective of those things. And that can present, again, in ways of people being less trustworthy. I mean, not trustworthy, less trusting or more distrustful of other folks. And just in general, being more overly aware and protective of their own safety. So trauma is an overwhelming external threat. So something that happens and comes from the outside in, and clients perceive, or humans in general perceive it to be danger. So when people experience trauma, it may not always be the thing that happened, but how it happened and the effects of what happened. So for example, you may have a client who survived a horrible car wreck, and it simply is not an issue for them. That is not a traumatic event. They did not experience it as a traumatic event, and they do not have side effects from that. You may have a client who is completely opposite. They may be afraid to ever get in a car again. So we can't assume that what happened to one person and the effect of that issue will happen to every person. Some people can be witness to extreme violence and not have the traumatic effect that other people may have. So we really need to make sure that we're understanding what the event is, what the trauma is that is impacting the person. Many times for the folks we work with, it's multiple traumas, and that's okay too. It's important to understand and make space for asking about or understanding or knowing what their trauma was. The other thing is that sometimes what people experienced as trauma, we personally think is not a big deal. And so we need to pay attention to our own biases and allowing ourselves to validate exactly what a client is telling us was traumatic for them. So when we think about trauma, there are 3 E's in trauma. So the events. So like I said earlier, what is the circumstances? What happened to cause the trauma? Now, for direct line staff or, you know, folks who are working immediately with folks on a day-to-day basis, you may not know this because that may be a social worker or a clinical person's information that's not shared with you. And that's okay too. But if a person is talking about the events, or if you have the opportunity to talk about the events, be mindful of what the causes are and what the situation was, because that's really important to the root cause of some trauma for folks. The second E is experience. What was it like for that person? Like, how did that trauma play out? Who helped them? Who didn't help them? What was useful for them? What happened before, during, and after? Was it a repeated trauma? Was it a repeated incident that happened to them, something over and over and over again over a long period of time? Was it something that just happened once or a few times? That may be important. It may not matter. Again, it's an individual's experience and how they understood and felt the trauma or the event that happened. And then lastly, we talk about effects. So what did the trauma do? How does it look like, right? How does it impact a person physically? Maybe some people have physical injuries or scars or bruises or cuts that, represent the thing that happened to them. Maybe the effect was social. Maybe they lost a social group of friends or lost their social status or their connection to other people. Or sometimes even family. Maybe we lose family from traumatic events. Emotional effects. What did that do to how I feel and respond? And spiritual consequences. Did that shake my core beliefs in how I believe and exist in the world? So the effects can be pretty intense, and some people may not even truly understand all the levels that trauma has affected them, and that's okay. And for a lot of us who are not clinicians, that's not our job anyway. That's the therapist's job, and that's okay. But when you work with folks daily, directly in their life, these things are going to present or manifest in different ways. And so some of the skills we'll talk about today is how to intervene knowing the 3 E's in trauma: events, experience, effects. And I think that these come up particularly in residential programs or in-home services when folks experience triggers and they're not necessarily aware of what the triggers are or what just happened. And as providers, we sometimes witness people being impacted by a trigger and not always understanding what's happening in that moment. So we will talk about safety as well towards the end of the presentation. Okay, so let's think about the process of trauma. We talked about the traumatic event, right? The first E, the event. So whatever the event may be is overwhelming physically and psychologically. So whatever skills we've used in the past to cope or self-soothe are just not going to work in this situation because the event is so intense. It is biologically, physically, mentally overwhelming. And then the body responds, right? We have a biological built-in response that our bodies were born with to respond to any sort of scary event. And we've all heard of fight, flight, or freeze. My best example for this is I definitely drive too fast. And frequently, because I drive too fast, I have to jam on my brakes. And if anybody's had to do that before, you can think about and maybe remember that overwhelming rush of feelings, or for me, it's like a tingly chemical feeling that overwhelms me because in that moment, my body is bracing for, is Michele going to hit that car? Is she going to stop and not hit that car, or is something else going to happen? And that is a biological response that we do not have control over. It's built in to help protect us. So what I tell people in that, if you think about when you're jamming on the brakes and you get that overwhelming rush of fight, flight, or freeze chemicals, some of our clients who have experienced repeated trauma or very intense trauma, their baseline, their everyday functioning is that heightened fight, flight, or freeze. So you can imagine if you felt like that all day, every day, it would start to take a toll on you. It starts to take a toll on your body, on your mind, on your ability to just function because it's so overwhelming every day. So the fight, flight, or freeze chemicals can sometimes allow the body to, or the brain to have altered state of consciousness, right? So what we might talk about as dissociation, or kind of the brain checks out for a minute or longer than a minute to sort of protect the body and the mind from what just happened. Body sensations, like I just talked about earlier, kind of that tingly, overwhelming, intense feeling. Numbing, right? So some people talk about like they just feel emotionally or physically numb. Hypervigilance, that's a fancy word for just paying attention all the time to all the things. So a lot of clients will check windows and doors to make sure that they're locked. Or again, ask about what staff are working and when, or how come this staff traded schedules with that staff. So they're constantly paying attention to any sort of changes because they're constantly trying to manage the environment as a response to their trauma. Hyperarousal, so again, fancy word for being mentally or physically overactive, right? So can be lots of fidgeting, or can't sit still, or emotionally agitated all the time, right? So hyper talking too much, or fidgeting too much, things like that. And collapse, right? So we've all seen the over dramatic TV shows where people experience or see something traumatic and they just collapse on the floor. That too can be something that happens. So these responses to trauma are things that you may not necessarily witness because it's already happened. However, you may witness the recreation of this if a client is triggered when you're around them and you're not quite sure what happened. So these things can come back up. And it may not be that it was a new traumatic incident in that moment. It can just be an old response to an old thing that happened. Okay, so then we move to the sensitized nervous system. So all of those fight, flight, and freeze chemicals can in fact create changes in the brain and the brain-body connection. So when I tell people this, they get really depressed and they're like, wow, like this is awful. Like literally trauma changes the brain, and what do you do about that? The good news is that with trauma-informed care and just really good clinical and therapeutic interventions at all levels, we can actually rechange the brain to function in a healthier way. And for me, that's the most exciting part about trauma-informed care, is that we're actually making new, healthier pathways for people in their brain and in the brain-body connection. And I explain that frequently to clients, and I think they find it to be very hopeful and encouraging that they can actually make those changes, particularly for clients who have struggled for a really long time. Next, we move to the psychological and physical distress. So we use the word trigger a lot. I like the word activated because I think triggers maybe lost its meaning a little bit. And if we think about activated, we can also think about the fact that something was deactivated. So something was stable or calm for a really long time, and then all of a sudden something clicks it on, and then it's activated. And so thinking about our clients and the community we work with, what are the current stressors? So in residential programs, is there not enough staff? Has the staff been working too many shifts? Is there a new client in the environment that may be a little bit disruptive to other folks? Reminders of trauma. And again, these can be really random and not understood right away, but sometimes they can be a smell, a food, a taste, a scent, a person who reminds them of somebody else, a color. it can be almost anything and sometimes impossible to know. But it is useful to try and understand with the folks we work with what that might be. So again, sensations, images can be particularly triggering for some people. Other people's behavior. If you have a group of people living together and one person is behaving in a way that reminds another person of someone else, that can be something that's activating and create response. Emotions and memory. And, I would add to this dreams and nightmares as well. And that may also lead to sleep disruption for some folks. Okay, so some of the physical responses, emotional and or physical responses, can be to retreat or internalize the effect of the trauma. So the way that this might look with your clients, and also maybe a clue for you as a staff to pay attention and try and talk with someone to see what's going on, is increased isolation. So really being by themselves more than usual, or really having difficulty getting along with others in the community, or even within their own family. Dissociation. So this is a tough one because sometimes you can have really extreme examples of dissociation. I once worked with a child, I would say they were about 12 or 13, and they were having a particularly upsetting physical, emotional outburst. And myself and the staff witnessed the child sort of relive and act out a traumatic event that had happened to them a long time ago. So it was upsetting for us, of course, and also upsetting to watch the child re-experience, relive, and react out something that had happened that was really awful a long time ago. So that's an extreme example of dissociation. I think more frequently what we see with dissociation is people or our clients present as like kind of checked out or not paying attention, or just somewhere else. And again, the work we do is stressful and complicated and not easy. And sometimes we don't always catch right away that that's what's happening. And we think someone's just ignoring us or not paying attention or not listening, when in fact it could be that they are dissociating. And sometimes for some folks who have experienced so much trauma, they may not even realize that they're checking out or dissociating. So that's an important thing to bring up with whoever their clinical person is or their therapy person is. Other symptoms that we may see is depression and anxiety. Now, again, all of these fancy clinical terms, we use them a lot, we talk about them a lot in everyday language, but what do they actually mean and what do they actually look like? So it's very frequent that trauma, attention deficit disorder, depression, anxiety, they can all look alike. And that's why we have clinicians to help us understand what's actually happening diagnostically. But sometimes the behaviors and the presentation is similar. So depression, sadness, lack of interest, changes in sleep or appetite, hygiene. Depression can be very obvious or very subtle. And again, relationship with our clients goes a long way so that we can notice those differences. Anxiety can present in lots of ways too. So someone can be actually depression and anxiety. You can have a lot of mood irritability. People can be cranky a lot. Asking lots of questions or questions that you feel like are too intrusive, making lists, checking things. Anxiety can be really disruptive for individuals and the community. And unfortunately, I think depression and anxiety are best friends. They hang out together a lot. So we see a little bit of both sometimes. Harmful behavior to self. So unfortunately, these are things that we see a lot with all kinds of folks that we work with. I think substance use disorders, I'm not sure people always think about or frame that as a self-harming behavior, but it really can be, right? It has a lot of negative personal impacts for the person and the environment. Eating disorders, again, you know, I would rely on clinical staff to help inform around some of these issues, particularly with eating disorders, self-harm and suicidal behavior. Those are things that you may have to intervene or see on a daily basis with the folks you work with, but also you should be working with and relying on clinical support to work around safety planning for folks with that, and identifying harmful behaviors to self. And then lastly, we look at the harmful behavior to others or externalized behavior. So these are really easy to see because they're usually really scary and easy to identify. So any kind of aggression, physical, emotional, verbal, any kind of violence, rages and threats. And all of these things in every category should really be taken very seriously for the individual as well as the community. Okay, so I gave you a lot of information around trauma, and now I want to talk about ACEs, so adverse childhood experiences, and what are they? And the information I gave you about trauma and the effect has a lot to do with how adverse childhood experiences impact individuals, and then when we work with them as adults, how they manifest or what they look like when we work with them as adults. Additionally, ACEs are very common, and we'll talk about that in a little bit. But also, as we talk about adverse childhood experiences, you may do some self-reflecting and think about your own life experiences. Many of us work in this field because we've had some challenging issues in our life and we want to give back, right? And so this may impact our ability to provide really great services for our clients because we can understand things from a place of health and healing and progress. So adverse childhood experiences is a questionnaire. It's part of a study that was completed. We'll watch a video and understand it in a little bit. But the questions are broken down into 11 categories. And as you can see here, each category, this is a quick summary of the questions that are asked in each category. And they are asked in relation to a client's experience as a child, so 18 or younger. So right here is the ACEs questionnaire. I've included a link, an active link right here that you're welcome to click on, and I believe it will also be included with the presentation. So you can in fact look at the actual ACE questionnaire for adults. At the end of the questionnaire, you add up the score, right? The total ACE score. And then the last question is, do you believe that these experiences have affected your health? And the options are not much, some, and a lot. I think if this form is used and the score is shared with direct care staff or line staff, I think it can be really helpful to understand or adjust your approach to working with your clients to give you a better informed approach. So ACEs impact health and well-being. The purpose of this study was to understand a few things. There were a lot of participants in this study, 17,000 adults, and they completed the confidential questionnaire. And from that questionnaire, we got the ACEs checklist, right? And they asked the questions about childhood maltreatment and family function/dysfunction. And then they asked questions about clients' current health status. Now, why am I telling you all of this stuff? Because sometimes a client's physical health or physical issues are easier to see and understand and focus on than the emotional ones. So sometimes you will have clients who have chronic illnesses or other health-related issues, and that needs to be a clue that we should be paying attention to what may have also happened to them as a child in regard to trauma. So health, physical health, and behavioral health are very intertwined and can work together. And I think staff who work directly with clients as opposed to clinicians can sometimes have more insight. So you all have greater opportunity because you have more client contact to see and understand what might be the physical health issues. So if we look at this sort of pyramid of concerns, and really the unfortunate, if untreated, physical, mental, behavioral health progression for folks with adverse childhood experiences. So at the bottom would be, what is your ACEs score? What is the trauma you've experienced in your life? And based on that, is there disrupted neurodevelopment? Again, fancy word for, were you on high alert all the time, and did it impact the way that your brain and body developed and responded to day-to-day issues or incidents in life? And did that disrupted neurodevelopment, or did those issues then create an issue of social, emotional, and cognitive impairment? So if you think about a lot of traumatic incidences on the brain changing the way that the brain works, did that have a long-term or significant impact on the way that a client is developing socially, emotionally, and mentally? Now, on top of that, we look at, are clients using not great ways of coping? So are they using substances? Are they smoking? Are they taking risks? Are they not taking care of their basic hygiene and health and well-being? And the effects of that can lead to disease, disability, and other problems, right? So if we're not taking care of our basic needs, or we're unable, then we're looking at more chronic health issues. And worst case scenario, all of this leads up to early death. And the reason we talk about ACEs and trauma-informed care is so that we can increase folks' odds of not having this pyramid of negative impact from adverse childhood experiences. So some of the impacts or some of the things that I think you will see that present in clients. Think about your clients, right? So let's start sort of at the outside bubbles in this picture. How many of your clients have traumatic brain injuries? How many clients do we not even know have traumatic brain injuries, and what actually causes them, right? So we always want to think that football players or athletes are the only ones who have traumatic brain injuries. The reality is a lot of regular day-to-day humans have them. People who have been in intimate partner violence situations, fist fights, or people who may resort to violence or have been exposed to violence may have had a history of traumatic brain injuries. So different kinds of injuries. Think about your clients with mental health concerns. I would imagine 100% of all the folks we work with are coming with some sort of mental health diagnosis. If we think about folks that may be pregnant or parenting or unintended pregnancies, children that were removed from care, or children that folks had to give up or were unable to care for in the way that they really wanted to. Think about our clients who may have long-term, medical issues like HIV, STIs, things that can impact their physical health, but also mental health. A lot of folks we work with have chronic disease, right? Cancer, diabetes, heart disease, asthma, high blood pressure. These are all things that a lot of our clients experience. A lot of the folks you work with have a history of alcohol and drug use, and may also have experienced some unsafe sex or sex that's not as safer, or even sex work to provide money for a living. And then what about education and occupation? So what are the folks that you work with, and what's their level of education and occupation? So anybody can be successful at any level with education and occupation, but did any of these other issues we've discussed impact folks' ability to achieve what they had hoped to achieve? So, like the title says, early adversity can have lasting impact. So all of these lasting impacts or long-term potential issues can come from or stem from adverse childhood experiences. So I use this because I think particularly for day-to-day direct care staff or line staff, what we typically see is the outside circle, right? And we don't always, or are not always, able to connect it to the adverse childhood experiences. And my hope is that if you're dealing with the outside circle issues, it will trigger you to think about, oh, maybe this is connected to something more. So ACEs are really common. 62% of US adults have at least one ACE. That's a lot of us, right? And 25% of US adults have 3 or more ACEs. And really, I think that's a lot of us too. So I also bring this up because I don't want folks to start thinking about themselves or their clients and like, oh my God, they have such a high ACE score, they're never going to be able to do that or be successful. But the reality is that your ACE score does not determine your outcome in life. Many of us with high ACE scores can be successful and achieve what we want to achieve in life. And I think ACEs and trauma-informed care can be really hopeful because it gives us the information to work with our clients in a way that can be more positive and successful. One of the other things we need to think about with ACEs is that there is an elevated impact and higher numbers of ACEs. What we found is in Black, Latinx, multiracial communities, folks with less than a high school education, low income, underemployed, unable to work, or the LGBTQIA+ community. And we need to think about what are the systematic issues that create these elevated levels for these different communities. I bring attention to this simply because if you have clients who fit into these categories, it is yet another indicator like that maybe they may have more ACEs, or maybe there's some more incidences of trauma that you should be paying attention to or could pay attention to. Okay, so a lot of talk about ACEs. So if we look at the picture of the tree and we look at the roots and then we look at the trunk and the leaves and maybe even the flowers. So if we look at the bottom, the roots, the adverse community environment, these are typically more institutional or system level, broad sort of impact for our clients. So things that we walk into or are born into or come into through no fault of our own. So poverty, historical discrimination, community disruption, lack of opportunity for economic mobility and social capital, poor housing quality and affordability, and violence. So the environmental adverse community topics typically are things that we have no control over as children. These are things that are placed upon us. And these are important things when we work with our clients to consider as an impact, because it's what our clients have grown up with and what they've experienced as children long term, that was just part of their environment. Then we look, unfortunately, the tree grows from the roots, and some of the adverse childhood experiences that come from the environmental or the community experiences. So the domestic violence, the substance use, the emotional and sexual abuse, maternal depression, which is a specific ACE question that's asked on the questionnaire, physical and emotional neglect, divorce or separation, mental illness of caregivers, incarceration of caregivers, and homelessness. So ACEs can impact the development of a healthy personal identity and community identity. So again, this is important for staff because it helps to inform the way that you intervene with your clients, because sometimes our clients don't even know who they are and how they are and what they are. And so that may be a nice place to start with them in order to keep them motivated and engaged in treatment, to help them develop those things. Perceptions of power. So many of our clients present us feeling helpless or not able to change or affect change. So again, another opportunity for staff to work with and join with our clients to help them regain some of that personal power. And I think the ability to negotiate comes with that as well, because with developing personal esteem and power, then we can be a little bit more motivated and have a little bit more ability to negotiate change. Sometimes ACEs impact and limit choice and number of support systems. Again, this is important because as staff, we can help intervene and work with our clients to allow them to see that they do have some choice, and they're in a position now, maybe not before, but now, to exert choice and have agency. And then lastly, ACEs impact understanding risk in relationship and environment. So what this means is if you are used to bad things happening all the time, you start to believe that that's normal or that's regular or that's to be expected. And you are desensitized to understanding that the environment does not need to be risky and unstable all the time, and that you can have a calm community. And the way that this presents for our clients is that sometimes we have some clients who love to create a problem. They love to create drama where there is none, or, things are going nice and smooth in a residential unit, and then all of a sudden one person creates lots of upheaval. And some understanding behind that is clients are not always used to things being calm. If things are calm, they're waiting for the next issue to happen. And so calm actually creates anxiety for some of our clients. And so how do they decrease anxiety? They create the drama because that's what they're used to. And so having some of that understanding can help us to better intervene and prevent some of the issues that we see with our clients on a day-to-day basis. Okay, so Nadine Burke Harris is one of my favorite people in the whole wide world. I think she's incredibly brilliant. She's wrote a very excellent book that I actually use in one of my classes. And I like it because it's really easy to understand. It makes a lot of sense and it's really short and it's also really cheap. So I would encourage any and all of you to look into this book if you're interested in all of this information and if you really want to try to understand this at a deeper level. And so what I would like to do now is actually play her TED Talk in which she talks more specifically about adverse childhood experiences.
In the mid-90s, the CDC and Kaiser Permanente discovered an exposure that dramatically increased the risk for 7 out of 10 of the leading causes of death in the United States. In high doses, it affects brain development, the immune system, hormonal systems, and even the way our DNA is read and transcribed. Folks who are exposed in very high doses have triple the lifetime risk of heart disease and lung cancer, and a 20-year difference in life expectancy. And yet doctors today are not trained in routine screening or treatment. Now, the exposure I'm talking about is not a pesticide or a packaging chemical. It's childhood trauma. Okay, what kind of trauma am I talking about here? I'm not talking about failing a test or losing a basketball game. I am talking about threats that are so severe or pervasive that they literally get under our skin and change our physiology. Things like abuse or neglect, or growing up with a parent who struggles with mental illness or substance dependence. Now, for a long time, I viewed these things in the way I was trained to view them, either as a social problem, refer to social services, or as a mental health problem, refer to mental health services. And then something happened to make me rethink my entire approach. When I finished my residency, I wanted to go someplace where I felt really needed, someplace where I could make a difference. So I came to work for California Pacific Medical Center, one of the best private hospitals in Northern California. And together, we opened a clinic in Bayview Hunters Point, one of the poorest, most underserved neighborhoods in San Francisco. Now, prior to that point, there had been only one pediatrician in all of Bayview to serve more than 10,000 children. So we hung a shingle, and we were able to provide top quality care regardless of ability to pay. It was so cool. We targeted the typical health disparities: access to care, immunization rates, asthma hospitalization rates, and we hit all of our numbers. We felt very proud of ourselves. But then I started noticing a disturbing trend. A lot of kids were being referred to me for ADHD, or attention deficit hyperactivity disorder. But when I actually did a thorough history and physical, what I found was that for most of my patients, I couldn't make a diagnosis of ADHD. Most of the kids I was seeing had experienced such severe trauma that it felt like something else was going on. Somehow, I was missing something important. Now, before I did my residency, I did a master's degree in public health. And one of the things that they teach you in public health school is that if you're a doctor and you see 100 kids that all drink from the same well, and 98 of them develop diarrhea, you can go ahead and write that prescription for dose after dose after dose of antibiotics, or you can walk over and say, what the hell is in this well? So I began reading everything that I could get my hands on about how exposure to adversity affects the developing brains and bodies of children. And then one day, my colleague walked into my office and he said, Dr. Burke, have you seen this? In his hand was a copy of a research study called the Adverse Childhood Experiences Study. That day changed my clinical practice and ultimately my career. The Adverse Childhood Experiences Study is something that everybody needs to know about. It was done by Dr. Vince Felitti at Kaiser and Dr. Bob Onda at the CDC, and together they asked 17,500 adults about their history of exposure to what they called adverse childhood experiences, or ACEs. Those include physical, emotional, or sexual abuse, physical or emotional neglect, parental mental illness, substance dependence, incarceration, parental separation or divorce, or domestic violence. For every yes, you would get a point on your ACE score. And then what they did was they correlated these ACE scores against health outcomes. What they found was striking. Two things. Number one, ACEs are incredibly common. 67% of the population had at least one ACE, and 12.6%, 1 in 8, had 4 or more ACEs. The second thing that they found was that there was a dose-response relationship between ACEs and health outcomes. The higher your ACE score, the worse your health outcomes. For a person with an ACE score of 4 or more, their relative risk of chronic obstructive pulmonary disease was 2.5 times that of someone with an ACE score of 0. For hepatitis, it was also 2.5 times. For depression, it was 4.5 times. For suicidality, it was 12 times. A person with an ACE score of 7 or more had triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the #1 killer in the United States of America. Well, of course, this makes sense. You know, some people looked at this data and they said, come on, you have a rough childhood, you're more likely to drink and smoke and do all these things that are going to ruin your health. This isn't science. This is just bad behavior. It turns out this is exactly where the science comes in. We now understand, better than we ever have before, how exposure to early adversity affects the developing brains and bodies of children. It affects areas like the nucleus accumbens, the pleasure and reward center of the brain that is implicated in substance dependence. It inhibits the prefrontal cortex, which is necessary for impulse control and executive function, a critical area for learning. And on MRI scans, we see measurable differences in the amygdala, the brain's fear response center. So there are real neurologic reasons why folks exposed to high doses of adversity are more likely to engage in high-risk behavior. And that's important to know. But it turns out that even if you don't engage in any high-risk behavior, you're still more likely to develop heart disease or cancer. The reason for this has to do with the hypothalamic pituitary adrenal axis, the brain's and body's stress response system that governs our fight or flight response. How does it work? Well, imagine you're walking in the forest and you see a bear. Immediately, your hypothalamus sends a signal to your pituitary, which sends a signal to your adrenal gland that says, release stress hormones, adrenaline, cortisol. And so your heart starts to pound, your pupils dilate, your airways open up, and you are ready to either fight that bear or run from the bear. And that is wonderful if you're in a forest and there's a bear. But the problem is what happens when the bear comes home every night. And this system is activated over and over and over again. And it goes from being adaptive or life-saving to maladaptive or health-damaging. Children are especially sensitive to this repeated stress activation because their brains and bodies are just developing. High doses of adversity not only affect brain structure and function, they affect the developing immune system, developing hormonal systems, and even the way our DNA is read and transcribed. So for me, this information threw my old training out the window, because when we understand the mechanism of a disease, when we know not only which pathways are disrupted, but how, then as doctors, it is our job to use this science for prevention and treatment. That's what we do. So in San Francisco, we created the Center for Youth Wellness to prevent, screen, and heal the impacts of ACEs and toxic stress. We started simply with routine screening of every one of our kids at their regular physical, because I know that if my patient has an ACE score of 4, she's 2.5 times as likely to develop hepatitis or COPD. She's 4.5 times as likely to become depressed, and she's 12 times as likely to attempt to take her own life as my patient with 0 ACEs. I know that when she's in my exam room. For our patients who do screen positive, we have a multidisciplinary treatment team that works to reduce the dose of adversity and treat symptoms using best practices, including home visits, care coordination, mental health care, nutrition, holistic interventions, and yes, medication when necessary. But we also educate parents about the impact of ACEs and toxic stress the same way you would for covering electrical outlets or lead poisoning. And we tailor the care of our asthmatics and our diabetics in a way that recognizes that they may need more aggressive treatment given the changes to their hormonal and immune systems. So the other thing that happens when you understand this science is that you'll want to shout it from the rooftops, because this isn't just an issue for kids in Bayview. I figured the minute that everybody else heard about this, it would be routine screening, multidisciplinary treatment teams, and it would be a race to the most effective clinical treatment protocols. Yeah, that did not happen. And that was a huge learning for me. What I had thought of as simply best clinical practice, I now understand to be a movement. In the words of Dr. Robert Block, the former president of the American Academy of Pediatrics, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. And for a lot of people, that's a terrifying prospect. The scope and scale of the problem seems so large that it feels overwhelming to think about how we might approach it. But for me, that's actually where the hope lies. Because when we have the right framework, when we recognize this to be a public health crisis, then we can begin to use the right toolkit to come up with solutions. From tobacco to lead poisoning to HIV/AIDS, the United States actually has quite a strong track record with addressing public health problems. But replicating those successes with ACEs and toxic stress is going to take determination and commitment. And when I look at what our nation's response has been so far, I wonder, why haven't we taken this more seriously? You know, at first, I thought that we marginalized the issue because it doesn't apply to us, right? That's an issue for those kids in those neighborhoods, which is weird because the data doesn't bear that out. The original ACEs study was done in a population that was 70% Caucasian, 70% college educated. But then, the more I talk to folks, I'm beginning to think that maybe I had it completely backwards. If I were to ask how many people in this room grew up with a family member who suffered from mental illness, I bet a few hands would go up. And then if I were to ask how many folks had a parent who maybe drank too much, or who really believed that if you spare the rod, you spoil the child, I bet a few more hands would go up. Even in this room, this is an issue that touches many of us. And I'm beginning to believe that we marginalize the issue because it does apply to us. Maybe it's easier to see in other zip codes because we don't want to look at it. We'd rather be sick. Fortunately, scientific advances and, frankly, economic realities make that option less viable every day. The science is clear. Early adversity dramatically affects health across the lifetime. Today, we are beginning to understand how to interrupt the progression from early adversity to disease and early death. And 30 years from now, the child who has a high ACE score and whose behavioral symptoms go unrecognized, whose asthma management is not connected, and who goes on to develop high blood pressure and early heart disease or cancer will be just as anomalous as a 6-month mortality from HIV/AIDS. People will look at that situation and say, what the heck happened there? This is treatable. This is beatable. The single most important thing that we need today is the courage to look this problem in the face and say, this is real, and this is all of us. I believe that we are the movement. Thank you.
Some of the big takeaways from that video clip that I want folks to really understand is when Nadine Burke Harris talked about it's not just bad behavior. A lot of the things that we see are the result of a very real biological impact and change on the brain, on the development based on the traumatic experiences. And so if you take away anything, please take away that, because I remember how frustrating it was to work with folks day to day, in and out, and wishing they would just change their behavior. And so I hope that this helps you to understand that sometimes it's not that easy. It is definitely possible and hopeful to make all of the positive changes that we're looking for, but it takes time and patience and trauma-informed care. I've included 2 slides that just talk about trauma and substance abuse, just to give folks a little bit more insight as to what's going on with your client base. You know, these statistics are pretty high in regard to folks who have experienced trauma and now have substance use issues, with specifically higher numbers for veterans, prisoners, victims of domestic violence, and first responders, which is interesting because first responders we forget about as seeing that trauma close up and front and center frequently, every day, multiple times a day. And then lower on the statistics is that individuals who have been diagnosed with post-traumatic stress disorder are 3 to 4 times more likely to develop a substance use disorder. So again, substance use treatment, you should automatically be thinking, what's the history of trauma and how can I use trauma-informed care to provide the best care for my client? And then just another slide of some more trauma and substance use disorder information. So for children, for individuals with both chemical dependence, alcohol dependence, and trauma who also experience childhood trauma, so it's an indicator that their symptoms were more severe and more intrusive. Which then results and can result in more severe substance use. And difficulty, or not difficulty, but needing even more support to maintain sobriety and recovery. Okay, so I just wanted to provide those. I know a lot of folks are working with dual diagnosis folks. Okay, so core principles of trauma-informed care, things that are really important to put in place for the folks that you work with, for both you and your clients. You want to think about safety, trustworthiness, collaboration, and mutuality, empowerment, voice and choice, mutual responsibility, and compassion. So what does that look like in plain language? So safety, and this is something that every agency should be providing, is physical and emotional safety. And that starts as soon as you walk into an agency, or as soon as you park your car or get off the bus, or the first person that you interact with at an agency, whatever that setting may be. Allowing for and providing choice and control. Clients should always be provided with informed consent. They should always feel like or be given choices. Everything we do, even if we feel like we don't have a choice, we do have choice. It may not be a great choice, but there's definitely always options and choices, and helping clients to understand that. Collaboration. So working together. We always want to make sure that the treatment team is including the client as part of the treatment team, and supporting community within the treatment facility or the agency that the program that you're working with. Trustworthiness and integrity. So again, making sure you're your best self when you show up to work, being respectful, having good boundaries, being appropriate, being consistent. Everything that a lot of people have not had for a long time. And empowerment. So again, always focusing on the positive, always reminding folks that they are making the right choices by being in treatment or seeking help, and that they are in fact changing their brain biology for the better. And I think that that's really exciting to highlight for folks. Okay, so client expectations using trauma-informed care. So this, again, is information to use when you're working with clients and when they present sometimes with difficult behaviors or a difficult mood when they show up. So thinking about expectations versus reality. When your client comes to the agency, or when you go to their house, wherever you're meeting your client, be mindful of or be prepared for, what is that client's history with your agency, with your company? You know, what's happened in the past? Was it good, bad, indifferent? Was it a multiple interactions with your agency? What are you as a staff walking into that may have nothing to do with you, but with the agency you represent? So clients, as a form of protection, have expectations. What is the history with you and that client, or with you and that community? Good, bad, indifferent. What was yesterday like? What was the last shift like? What was last week like? What are you bringing to the interaction? What is the client bringing to the interaction? What expectation that's maybe not spoken? And then what happened today, right? So did you wake up and not get to have your coffee in the morning? Did your cat puke on the floor and you had to clean that up and it made you late for work? Did your heat break? So what are the things that happen to us as staff that are normal, everyday disasters that happen to create complicated days for us? And how has that impacted our attitude and ability to interact in a positive way with our clients? And that's really tough because particularly in the past few years, I think we've all been struggling with trying to find the energy and motivation to show up for our clients every day. Okay. So your expectations, again, thinking about how am I feeling today? How am I feeling about this interaction with this client? There are some clients that we really struggle with for our own reasons, or they struggle with us. And we have to check in with ourselves to make sure that we are prepared and ready and feeling at our best to do our job. Again, thinking about what external factors may be impacting you. Are you struggling to pay your rent? Are you struggling with another staff that you work with? Are you bringing that stress with you to work when you have your interaction? Is this client triggering you? So the interaction goes both ways. Clients can trigger us and we can trigger them. So does a client remind you of someone? Or do you just not like a client? Or, is there something they do that really gets under your skin? So what are you feeling and thinking walking into an interaction with a client? What do you want to do right now? I want to quit my job. I want to run away. I want to take a time out. I want to go and grab a coffee. Where's your head? Where's your mind at this interaction with your client? And how is that presenting or showing up to your client? What are they seeing? And we all know clients know us better and can read us better in 2 minutes than we think we're hiding. So be prepared that they are going to call you out and see your stuff. So I'm not saying we all need to be perfect and we all need to have a great life and, it's Little House on the Prairie. That doesn't exist for any of us. Well, what I am saying is just kind of check yourself before you show up to do your job and be honest with yourself, and sometimes be honest with the client if that's appropriate. Also know when to step back. Do you need a break? Okay. Do you need a break? In general, how resilient are you feeling? Okay. So the 4 R's of trauma-informed care is to realize the impact of it, to recognize the symptoms, to respond appropriately, and to resist re-traumatizing. So, de-escalation techniques. Frequently, clients present as anger. What I want folks to remember is that anger is the most easy emotion to understand, and it's immediate. So what I want you to do is try to pay attention to what's the underlying feelings or what's the underlying things that are happening before the anger: hurt, sadness, fear, all of these things that we're not allowed to talk about but are really happening that we communicate with anger. So we always want to think about safety first for yourself and for your clients, and there should be agency policy and procedure that discusses that. Communication is the most important. So I'm going to run through some of the immediate response tips, and I feel like maybe I spent too much time on the trauma and not enough time on the tips, but you can definitely go through these and just be mindful of checking with yourself and what can you do, how can you support your staff that you're working with each other and supervisors and vice versa. So what are you feeling? What do you want to do? How are you displaying this? Using reflective listening, so validating what our clients are saying to us and then allowing them to express themselves as long as it is calm and safe. Always offering choice. It's, if possible and safe, it's always great to sort of remove folks from the audience. And so if you can safely take a walk, even if it's around the block or around the building or down the hallway, providing space and privacy. Adjust your tone. Again, sometimes we get activated and we need to be mindful about how we're responding. Posture, right? So we never want to stand over people. We never want to touch people. We want to be calm and open, accepting, validating, and safe. here's another like really brief list of de-escalation techniques. Always respect personal space. You know, the greatest rule is sort of arm's length, so that everybody feels like they have space to escape or just good boundaries. Don't be provocative as in language. Try not to instigate. Using verbal contact, eye contact may not always be appropriate and in fact could escalate a situation. Keep words simple, sentences simple, language direct. Identify feelings, try to remove individuals and keep it focused on the incident or the issue. Limits, setting limits because there needs to be safety first. Always trying to find choice, even if they're not great choices, and always allow for debriefing for clients and for staff. Trying to remember to be focused on empathy. We work with humans because we are empathetic humans, and providing that to them. Behaviors have meaning. Try to understand that by asking questions. Try to, after everything has calmed down, try to, when everybody's ready, try to go back to discuss the situation to better understand it. Focus on the event. Focus on the issue that happened, not the individuals that were involved. That can sometimes make something get a little bit more unruly and out of control. Focus on the incident. And holistic response, making sure that we're meeting all the goals. Do you need food, water, shelter, safety, empathy, a meeting with your clinician? Try to think of all the things that can impact providing empathy for a client. And lastly, self-care. This is really important. And I always recommend keep it simple, ask for support and encourage each other, your fellow staff, and also ask administration to create opportunity for self-care and be creative about it. I've provided a short list that's really easy, cheap, free, and accessible. And in fact, you could do for yourself or with you and your clients. Okay. So again, I want to thank you all very much. I hope this was helpful, and I hope that you can use all of the information to better inform your interactions with clients and also better understand your reactions for yourself. And I just know that you all are probably doing a fantastic job, and I hope that this information helps you to continue to do that and grow as providers. And you're always welcome to call or email to get in touch with me. Thanks so much.